Good morning, everyone. Thanks so much for being here today to observe National Hepatitis Testing Day. I'm Karina Dan, the Viral Hepatitis Policy Advisor in the Office of HIV, AIDS, and Infectious Disease Policy at the U.S. Department of Health and Human Services, and I'm honored to be your MC for today's event. Before we begin, I want to thank our partners at the White House for hosting the event and for all of their work to make today happen. I want to thank all of you for being here today on Hepatitis Testing Day. And I want to thank everyone watching the live stream and welcome all of you to today's Hepatitis Testing Day at the White House. Everyone can also join the conversation on social media at hashtag HepTestingDay. So we have a packed agenda. Let's get it going. Starting off today is the Director of the Office of National Drug Control Policy, Michael Botticelli.
Thank you, Corinna, for all the work that you do. And good morning, everybody, and welcome to National Hepatitis Testing Day at the White House. It's good to welcome all of you. It's good to see a lot of familiar faces who have been doing this work for a very long time. I also want to thank Amy Lansky and the Office of National AIDS Policy for co-hosting this event. I was telling Amy that for a very long time we actually shared Amy between ONAP and ONDCP. So I feel a little kind of pride of ownership in terms of her position there. But I think it speaks quite honestly to how we at the federal level and across federal agencies work together, and I think it's really important. When I was at the state level doing both substance use work and HIV work, I would often say, if you federal folks could only get your act together and work to do that. So clearly we have a strong role to play in terms of how we work together as federal agencies and make sure that we're delivering the best and most holistic health care possible to the people who need it most. I want to thank Karen DeSalvo and her leadership at HHS for all of this work. Rick Walensky, who is a great partner in this work, and Carol Johnson, who you'll hear from later at DPC. So we're here today to really, and I also want to welcome Congressman Johnson, who's been a real pioneer in leadership in this work in Congress, and it's really important for us to make sure that we have the support of everyone in this critically important work. So we're really here to talk about an important issue that intersects with many of this administration's top priorities. The CDC estimates that hepatitis C infections were up more than 80% in 2013 from 2011. This dramatic increase, we know, is largely a byproduct of the ongoing opioid epidemic that's affecting families and communities all across this country. Today, we'll be talking about the role opioid misuse plays in spreading infectious disease like hepatitis and HIV, what the federal government is doing to stop it, and what we can achieve by working together and coordinating our efforts. President Obama has made clear that addressing the opioid epidemic is a top priority for his administration. One major consequence of this epidemic is that while very few people who misuse opioid pain medications move on to heroin use, 4 out of 5 newer users to heroin started misusing prescription pain medication, contributing to a significant increase in the number of people who inject drugs. Of course, we know that hepatitis and other viral infections like HIV are spread through needle sharing. We saw that happen dramatically in Scott County, Indiana last year, with the spread of HIV and hepatitis caused largely by people sharing needles. We know this is preventable. Hepatitis, HIV infections, and substance use disorders can be prevented and treated. We have to make sure we're doing everything we can to stop the spread of these infectious diseases. Here are a few ways that we can do this and making progress on ending our opioid crisis at the same time. First and foremost, we need to expand access to substance use disorder treatment, especially in underserved areas like Scott County. We know that there is no one-size-fits-all to the solution to substance use, but we need to make sure that all forms of evidence-based treatment are available to people, because what works for one person may not work for the next. This includes medication-assisted treatment, which needs to be the standard of care for people with opioid use disorders. Helping people move into recovery will reduce their likelihood of contracting hepatitis and HIV. But we know, unfortunately, there is a huge treatment gap. And many of rural parts of the United States that are a significant risk for HIV and substance use disorders have no infrastructure to help support their work. Too few people who need treatment for their disorder are able to get it. Syringe service programs offer needed referrals to treatment for opioid use disorders, and more opioid treatment programs need to offer testing on-site for hepatitis. The importance of rapid on-site testing for infections and engagement in medical care cannot be overstated. We need opiate treatment programs and providers offering medication-assisted treatment for opioid use disorders to set up and offer this testing, and we need more treatment providers and facilities. That's why President Obama has called on Congress to pass $1.1 billion in new funding on his proposed budget. We have to make sure that every American with an opioid use disorder who wants treatment can get it. This funding would also support the placement of treatment providers in the communities most at need and would continue to develop effective treatment programs. The President's budget builds on current administration efforts to expand evidence-based prevention strategies, increasing access to the opioid overdose reversal drug naloxone, improve prescribing practices for pain medication, and support targeted enforcement activities. Last week, the House voted to approve a package of bills to address the opioid epidemic, and we appreciate their support. But we need them to appropriate money so they can do more than just raise awareness. We need to close the treatment gap in the United States. We need them to pass the President's budget so we can expand treatment for people with substance use disorders. But we also know that funding isn't our only barrier to expanding treatment. We also have an enormous hurdle to overcome, and that's shame and stigma. Stigma is an obstacle for people reaching out, reaching recovery, and living healthy and productive lives. That's because stigma breeds prejudice, discrimination, it alienates and isolates people, it prevents them from accessing treatment, and even seeking it in the first place. It says you should be ashamed because you have a disease. In fact, research has shown that when we use terms like abuser and addict to describe someone with a substance use disorder, that person is actually less likely to be offered treatment or to receive treatment, and often contributes to negative public policy. And this stigma extends to other aspects of recovery, including housing and employment opportunities so needed for people to be stable in their recovery. We're building partnerships to address the opioid epidemic, and this core principle of the federal government's Viral Hepatitis Action Plan will help us reach people affected by hepatitis. And of course, we need greater focus on implementing and expanding syringe services programs. The Centers for Disease Control and Prevention estimate that in 2013, 30,500 people became infected with hepatitis. That's an average of 84 people a day. Studies have shown time and time again that syringe services programs work. We know that people who inject drugs don't use syringe services programs. We know that people who inject drugs and don't use syringe services programs are 7 times more likely to contract hepatitis C. Despite this, many people don't have access to these important public health programs. And we really appreciate Congress, who previously banned federal funding for syringe services programs, but President Obama signed into law in December a revision of that ban so funding can be used to support many aspects of these programs. And we thank Congress, and it's a big step forward. Plus, we know that syringe service programs are effective in linking people who inject drugs into treatment programs. The evidence is clear. Syringe service programs work and will help us reduce the consequences of the opioid epidemic, including the number of new hepatitis and HIV infections. Everyone has a role to play. Whether you work in government, whether you're an advocate for awareness, testing, and treatment, whether we're working to engage other stakeholders or are leaders in the pharmaceutical and medical industries, each and every one of you can make a real difference. We can bring our new infection rates down, and we can end the opioid epidemic. And if we all redouble our efforts to raise awareness, break the stigma, and encourage people to get tested and seek treatment, we'll get there. As President Obama said in West Virginia last October, when it comes to substance use, treatment, and recovery, these things are all possible if we work together and if we care about each other. So thank you for everything you're doing to end this crisis. I'll now turn it over to Dr. Amy Lansky, the Acting Director of the Office of National AIDS Policy, for opening remarks. As many of you know, before taking over as Director, Amy was a Senior Policy Advisor for both ONAP and ONDCP. She brings many years of experience at the Centers for Disease Control and Prevention, working in the Division of HIV/AIDS Prevention on a wide breadth of issues, including persons who inject drugs, sampling methods for reaching high-risk populations, the uptake of HIV prevention guidelines, and HIV testing behaviors. We are really lucky to have her experience, her compassion, and her expertise. So, Dr. Lansky.
Good morning. Thank you, Director Botticelli. I still have to use that formal title. I can't quite do that. I wanted to also express my thanks this morning to our colleagues at the Office of National Drug Control Policy and at HHS and recognize their work on hepatitis and substance use and HIV. And also extend that thanks to all of you who are participating today, who work on the front lines in education, advocacy, prevention, care and treatment, and research, and to those who provide support for this important work. Since 2012, the White House has hosted events to recognize World Hepatitis Day in July, but this year we decided to bring things home and mark National Hepatitis Testing Day today on May 19th to focus or highlight the need for Americans to be tested for hepatitis and to focus on the other public health and substance use issues that are so closely related. For those of you who may not know the Office of National AIDS Policy, our primary job is to coordinate implementation of the National HIV/AIDS Strategy, which serves as our national roadmap to improving the lives of people living with HIV, people at risk for HIV, and ultimately working to end the HIV epidemic in the United States. Our National HIV/AIDS Strategy, released by President Obama in 2010 and recently updated through 2020, guides our work in HIV prevention, care, and treatment. We've made notable progress since the strategy was first released in terms of expanding our prevention toolkit, bringing more people into care, especially through the Affordable Care Act, modernizing our testing and treatment guidelines, focusing on improving the HIV care continuum from testing through to viral suppression, aligning our resources with the burden of disease, and staying grounded in the most up-to-date scientific research and data. Our strategy has 4 goals: reducing new HIV infections, increasing access to care and improving health outcomes among people living with HIV, reducing disparities, and achieving a more coordinated national response. And each one of these goals addresses viral hepatitis in some way. Viral hepatitis has a visible role in our HIV strategy because it's an important factor in HIV prevention and care. And I know that Dr. Ward will tell you a lot more, but some of the things that we know are that 1 in 4 people living with HIV also have hepatitis C virus, and it's higher among people who inject drugs who are living with HIV. Up to 4 in 5 are estimated to have hepatitis C virus infection as well as HIV. People with HIV and viral hepatitis co-infection can have serious medical complications. For example, hepatitis C infection progresses more rapidly to liver damage in HIV-infected persons, and hepatitis C infection may also impact the course of HIV infection. And so that contributes to why we recommend that all HIV-infected people be screened for hepatitis C virus infection, and those who are susceptible should be vaccinated for hepatitis B virus. Routine screening for multiple conditions and considering multiple risks and healthcare needs allows us to identify infections earlier and provide linkage to effective care and treatment. Our National HIV/AIDS Strategy addresses the importance of screening for multiple conditions among people living with HIV, including substance use disorders and viral hepatitis. And in support of that recommendation, the President's budget for fiscal year 2017 highlights a $9 million initiative at HRSA to provide hepatitis C virus treatment for people living with HIV. Our strategy also addresses the need to support routine screening for HIV and viral hepatitis and substance use treatment programs, as Director Botticelli alluded to. As part of our National HIV/AIDS Strategy's Federal Action Plan, which documents commitments by our federal agencies to implement the strategy, SAMHSA has committed to continuing their practices of routine screening for HIV and also incorporating hepatitis C virus screening. We have to be clear about how the risks for viral hepatitis, HIV, and substance use disorder are related and what the adverse health consequences of hepatitis and HIV co-infection are, because the solution demands that we address not just the opioid epidemic, not just the increases in hepatitis B and hepatitis C infections, and not just HIV infection, but that we address all of these issues and in a coordinated way. We have to address viral hepatitis, HIV, and substance use issues together to help break down the stigma associated with each, and that's compounded by their relationships to each other. Some of the actions to address these issues in our strategy's Federal Action Plan include a plan from HRSA for developing and implementing training for healthcare providers to increase their capacity and ability to serve affected populations, including in that training medical management for HIV and viral hepatitis co-infection. Other action items from CDC and HRSA and SAMHSA focus on identifying and promoting promising models of integrated care for testing, linkage, and treatment services. We really have to address these issues together and in a coordinated way. And it's this type of coordination and collaboration that's embodied in the fourth goal of our strategy, which is achieving a more coordinated and national response. That coordinated response will come from working together across agencies at the federal, state, tribal, and local levels, working together across public health systems for viral hepatitis and HIV, and working together across the substance use and infectious disease communities. Today, you're going to hear a lot of good examples of coordination and collaboration to provide testing and care for people at risk for or living with viral hepatitis. So welcome, and let's get started.
Thank you, Dr. Lansky. Now I'd like to introduce Dr. Karen DeSalvo, the Acting Assistant Secretary for Health. Dr. Salvo is also the National Coordinator for Health Information Technology and has a long history of work in public health and healthcare transformation. She will provide remarks and then present the HHS Viral Hepatitis Testing Recognition Awards. Dr. DeSalvo?
Well, y'all should thank Karina for giving you the shortened version of that bio. We'll start with that. God bless you. Good morning, everybody. I'm really delighted to be here today. I want to thank Director Lansky and Director Botticelli for being such terrific partners. We would not be able to have made the advancements that we have in this country without not just their work independently, but also the coordinated partnership between all of our agencies. And I think I want to make sure I share with you that kind of emphasis on viral hepatitis and on public health goes all the way to the top. President Obama, Vice President Biden, HHS Secretary Burwell all have been very public about their leadership and commitment to this issue. And I know all of you are here today in this room because you share that kind of commitment. I want to welcome you to the White House, and I want to welcome those who are watching via live stream. This is a really diverse group of stakeholders, and I hope you all have a chance to talk and meet with folks that you may not have met before. It's a group of people who are public servants, who are frontline providers, public health leaders, advocates, and that's not by mistake. That's very deliberate because it's going to really take a really diverse set of stakeholders to make sure that we can get the action that we need on viral hepatitis. You're all here today because you know that we have to increase rates of detection, of testing of hepatitis B and C, because it's a critical part of health of all Americans. The challenge is that more than half of people who are infected still don't know. So in spite of all the great work and advancement, we have a lot of work ahead. And because they don't know, they also don't know that they're at increased risk for complications like serious liver disease, including liver cancer, and also for transmission to others. And so what we need to do today is make sure that not only those of us in this room, but we continue to carry forward the message of the importance of testing for hepatitis B and hepatitis C. And just a reminder that for those who have been either born in Asia or Africa or their children, they should be tested for Hep B. And hepatitis C would be all the baby boomers like me, born between 1945 and 65, plus those with other risk factors like blood transfusions before 1992, or those who have been injecting drugs. It's so important that we get tested. It's also important to recognize that hepatitis can be preventable, and we need to take all of the right steps. We really have made some considerable progress in the last 2 decades. And if you just think about the success of vaccines in treating hepatitis B, we've seen an 85% reduction in infections of hepatitis B since the vaccine came out in the 1980s. And even more exciting than that, today we are able to say that we actually have an effective cure for hepatitis C that can cure 9 out of 10 people. And the treatments are simpler than ever, requiring only 2 to 3 months of treatment. The progress has been made possible not just because of the work that we're doing, but we are fully aware it's because of the people in this room, the people watching online, and all the collective work that we are doing together. But unfortunately, that progress is being threatened not only because of issues in viral hepatitis, but because of some of the issues that you've heard about this morning. You have to only turn on the television, look online, talk to your neighbors, read the paper to know that our nation is in the midst of a significant public health crisis around opioid use, and it is a full-scale epidemic. It is actually killing more Americans today than automobile accidents. And what really many people forget is that it is directly linked to other public health challenges like viral hepatitis. These issues are not happening in a vacuum. They actually compound each other. So when opioid users, for example, turn to injecting, then that can increase viral hepatitis rates. And the numbers that we're seeing actually are telling that story to us. Hepatitis B is beginning to increase. There's a 5% increase between 2012 and 2013. In the years from 2010 to 2014, we have seen a dramatic 250% increase in the rates of hepatitis C infection. And what's more distressing is that people are actually dying of hepatitis C even when there is treatment available. Just to put this into context, there are 61 reportable infectious conditions, and 19,000 deaths happened from hepatitis C in the year 2014. That was more than all the other 60 disease conditions combined. We're also seeing a connection between viral hepatitis and HIV. This is well known to many of us in the clinical community, and one of the most important things that we have to look for co-infection. Among people who have HIV who also inject drugs, 1 in 5 will have hepatitis C, and too many people are dying because they were lacking access to care and the treatment and prevention that they need. It goes beyond just the treatment in the clinical environment. Really, if we want to get ahead of this and all of these public health crises, we're going to have to really understand how we can tackle not just the medical determinants of health, but the social determinants of health. Everything ranging from poverty to social isolation, segregation, unequal access to health care. Because public health is really the collective actions of a society to ensure the conditions in which everyone can be healthy. And that means that we all have to come together around viral hepatitis, around the opioid crisis, around HIV, around all the public health challenges we face in this country, all to the betterment of the health of our neighbors. We've been making just those sorts of issues a priority in this administration. In addition to requesting the $1.1 billion to combat our opioid epidemic, the President is taking additional action to see that there's access to treatment, that we can prevent overdose deaths, and that we can increase community prevention strategies. Secretary Burwell has made the opioid crisis a top priority for her, and our leadership has been all hands on deck, particularly in 3 areas. One is making sure that we're improving training and educational resources for providers, for doctors, for dentists, others on the front lines, including the Surgeon General's new initiative to reach every clinician in this country and help them understand the appropriate use of pain medication. Secondly, to see that we're appropriately developing and distributing naloxone so that it's available on the front lines. And thank you to all the communities, those public health departments out there who are taking action on their own to see that it's available on the front lines. And third, expanding the use of medication-assisted treatment. We've also been stepping up our efforts around the intersection of hepatitis C and HIV. I hope you note that in the President's budget, there's an included $9 million for the SPINS program, which is a demonstration project at HRSA that I hope Jim will talk about later for patients who are receiving medical care supported by the Ryan White Care Act. And through our Secretary's Minority AIDS Initiative Fund, we have a new 3-year project of $7.8 million to look at expanding both screening and treatment. We've also been focusing on cost. We know that for too many people, it's out of reach to have the treatments and even just the diagnostic testing. Because of the Affordable Care Act, 20 million people in this country now have access to health insurance coverage. And though our work is not done, we are now dipping below 10% uninsured rate in this country for the first time, and it is an historic accomplishment that we should all clap for. We have people to reach, especially in those states that have not expanded Medicaid. My home state of Louisiana is on the cusp of doing just that in July, and I so hope that other states will work with us at HHS to find a way forward to see that the access to insurance coverage is not a barrier to people's health. We've also been working with state Medicaid programs to see that they have clarity about their opportunities to negotiate the cost of drugs, and the President's budget calls for the Secretary to have the opportunity to negotiate for drug pricing. We are also working to update the nation's viral hepatitis action plan to carry us through to 2020. This is an effort that is no small task for Dr. Walitsky and his team to bring together some 21 agencies from across government so we can be thinking in not just a medical fashion or even a public health fashion, but how can we tackle this public health challenge addressing all of the determinants of health. We are going to be aiming not only to get everyone aligned, but also to see if we can find ways to reduce death, reduce morbidity, and to do earlier detection, and to reduce disparities. All these federal efforts are not enough, because what we know for a fact is that we need to do this in partnership with all of you. It's going to take our collective action to see that together we can eliminate disparities, to see that we can eliminate viral hepatitis, to see that we can have an AIDS-free generation, and to see that people can have appropriate pain treatment, but at the same time not have an opioid crisis that is killing people unnecessarily in this country. We are so excited by the kind of work that you guys are doing on the front lines, and I know that this is hard work. I know that reaching into communities that aren't sure that they trust you coming at them from institutions, even if it's from public health, is hard work, and that it takes engagement recurrently with communities that we really need to make certain that we are reaching. And so I thank you all for that effort and that work that is ongoing, and I ask you not to let up the gas, because we are just really beginning this work. We still have half of the people who are infected with viral hepatitis that we need to reach. You look at a place like New York, where they're thinking systematically about how they can work from the bottom up and the top down to reach people in their community, where they're making sure that all baby boomers who have access to primary care, inpatient care, are getting asked about getting a Hep C test, where they've got an agreement with all the insurers that there's going to be access to treatment when people are found to be hepatitis C positive, and where everyone is working up to make sure they're doing screening at every potential opportunity. These kinds of coordinated efforts are what we are seeing across the country and are going to make sure that everyone's going to get tested. We want to help that from a policy frame, but we need you out there in the front lines making sure that it's getting done. And so it's in that spirit that I have the wonderful opportunity today to present HHS Viral Hepatitis Testing Recognition Awards. These 12 organizations, the team believes, represent the best of the best across the country who are doing what they can to make a difference in the lives of people on the ground. They're ensuring that their communities are getting tested, that they're getting linked to treatment, and I want to thank them and others out there who are doing this work every day. So today, on National Hepatitis Testing Day, we can think of no better group for recognition. So Karina is going to join me back up on the stage, and we're going to ask these folks to come up and receive their awards. Thank you all very much for the work you do. Keep it up.
Thank you, Dr. DeSalvo. So if I could have you pass out each award, and we'll get an individual picture with you and the awardee, and then the awardees will stay up on stage and we'll get a group picture at the end. But so I'm going to read them off. We're going to go pretty quick here. Hepatitis B testing, Hepatitis Testing Day Award recipients for Hepatitis B testing: the Charles B. Wang Community Health Center in New York City. Perry Pong. We can, yeah. Dallas-Fort Worth Hepatitis B Free Project in Texas, Tyler Smith. Holy Name Medical Center in Teaneck, New Jersey, Kyung-hee Choi. Kalihi Palama Health Center in Honolulu, Hawaii. Shirley Tamoria. And for hepatitis C testing, See a Difference in Philadelphia, Pennsylvania, Stacy Truskin. Cherokee Nation in Oklahoma, Jorge Mera. Rhode Island defeats hepatitis C in Providence, Rhode Island, Dr. Lynn Taylor. University of Texas Health Science Center at San Antonio, Center for Research to Advance Community Health. Reach Center, Barbara Turner. Now we have 4 organizations that do hepatitis B and C testing. The Asian Pacific Health Foundation in San Diego, California. Bin Tran, accepted by Sandy Chong. The Hepatitis B Initiative of Washington, D.C., Jane Pan. Hep Free Hawaii in Honolulu. Heather Lusk, accepted by Chris Taylor. And the Wyoming Department of Health Communicable Disease Unit, Courtney Smith. Wonderful. If I could ask all of the awardees to come up to the front of the stage so that we can get a group picture with Dr. DeSalvo. And wanted to remind folks that there is a press release out on the front table that describes just a little bit about what each of these wonderful organizations is doing to increase awareness about hepatitis B and C in the United States. Awesome. Thank you all. Thank you all for for your work on viral hepatitis, and thank you, Dr. DeSalvo. Yes. Now, it is my pleasure to introduce Dr. John Ward. Dr. Ward is Director of the Division of Viral Hepatitis at the Centers for Disease Control and Prevention, where he is responsible for research, surveillance, policies, and programs to prevent viral hepatitis transmission and disease. Dr. Ward is an amazing champion for viral hepatitis. Working domestically, he initiated and helped to develop the first viral hepatitis action plan in 2010. He's also very active globally in collaboration with the World Health Organization and many others. Dr. Ward will present on the epidemiology of viral hepatitis from the most recent surveillance information released earlier this month. And I would like to just say a special thank you for joining us here today on your birthday, Dr. Ward.
That's right. Shouldn't have said that. Well, what better place to have your birthday than at the White House, right? And on National Hepatitis Testing Day, no less. It's great. And it's really heartwarming, truly, to be able to come to these types of events. I really feel like so privileged to work with so many of you, and your commitment is so inspiring for people like myself. And I have several people from my division here, and a larger number are up viewing from Atlanta. And it's really great to see the type of work you do locally, because we can only do so much at CDC, and really where it all happens is locally. And I just want to say thank you and congratulations to the people who have just been recognized. What I was asked to do was to spend a few moments and sort of set the groundwork about, make sure everybody knows sort of the numbers and what we're up against. As I will be doing, we'll be looking at the epidemiology quickly, also looking at some of the prevention successes, as well as some of the prevention opportunities that are before us. And if we're successful in those, as we've had been in the past, we can truly begin to talk about the elimination of hepatitis B and hepatitis C in the United States. Just to set the, as a starting point, we really have 5 forms of viral hepatitis in the world. Importantly, 2 are enterically transmitted in situations of poor sanitation. They cause acute disease for the most part, not chronic infection. Hepatitis A was a big problem before the vaccine era began in 1996. The incidence of that has declined. Hepatitis E is a big problem in many countries of Asia and Africa, particularly for pregnant women, and improved sanitation, and most recently a vaccine has been developed that hopefully will be making a difference there. But we really want to direct our attention to hepatitis B and hepatitis C. They're different from the other ones that I've just described in 2 important ways. Number 1, they're perennially transmitted, meaning exposures to blood and bodily fluids. And number 2, they cause chronic infection. That chronic infection leads to progressive liver damage, progressing on to cirrhosis, liver cancer, and in the case of hepatitis C, causing a myriad other forms of extrahepatic manifestations, including diabetes and lymphoma, just to name a couple. There's an appreciable lifetime mortality risk if you're infected with these either of these viruses. We have prevention opportunities, particularly for hepatitis B, vaccination, but then limiting exposures to contaminated blood in healthcare and among persons who inject drugs, particularly for hepatitis C, which is what we're really going to be focused on today in particular. The burden of these 2 infections in the U.S. Is appreciable. Hepatitis B, we estimate 850,000 to as many as 2.2 million, with only about a third of those people being aware of their status. In the case of hepatitis C, 2.7 to 3.5 million living with hepatitis C, and as was mentioned by Dr. DeSalvo, only about half of those people are aware. In 2014, almost 20,000 persons died of hepatitis C, a progressive increase since the early 2000s, and one that I find more and more unacceptable in the era of highly effective, short-acting curative treatment. Next slide, please. We want to start the hepatitis B story with just to note the remarkable prevention accomplishment that is afforded by a hepatitis B vaccination program. where with progressive expansion of hepatitis B vaccine, as listed there on your left, we've had a decline in incidence. One particular challenge that we do not want to lose sight of as we look at testing and linkage to care and treatment is infants being born to hepatitis B infected mothers. Now, many of those are protected through a birth dose of hepatitis B vaccine, but only about 70% of infants in the U.S. get that vaccine currently. We want to get that up to 95%. Secondly, we want good testing of all mothers if they are infected to have the resources to provide the case management that can improve that prevention even more. Unfortunately, about 1,000 infants continue to get infected with hepatitis B every year, despite our best efforts. One new strategy that we are looking forward to implement is to provide antiviral prophylaxis to mothers that have a high viral load of hepatitis B so that that infant does not have a breakthrough infection even though they get vaccinated. Because of those declines in incidence within the U.S., the greatest contributions to the burden of hepatitis B over the last number of years has been through migration from countries where prevalence is particularly high. And in those countries, people are getting infected at the time of birth, as I've just described, or in young childhood, where they have the greatest likelihood of remaining chronically infected once infected. And in the U.S., about 60% of persons were born in China, the Philippines, or Vietnam who are migrating to the U.S. with hepatitis B. So we've done our best efforts of directing our educational programs to meet those cultures and differences in language, et cetera. So this is very much a disease of Asian Americans in particular. They represent about 40% of all chronic hepatitis B cases reported to the U.S., even though it represents 5% of the U.S. population. They represent the majority of mothers who are hepatitis B infected. They have large disparities in liver cancer rates and mortality because of this hepatitis B prevalence difference. And we know if we can get them tested and linked to care, you can have a dramatic improvement in their prevention of liver cancer. Now, these communities can be accessible if you have the resources to develop a program that's socially and culturally appropriate for them. This just shows you the robust response to a testing and linkage to care program around the country. You'll note the high prevalence there in the top line, and how the biggest challenge continues to be helping those people with navigation services to attend that appointment that's been made for them. Next slide. Turning to hepatitis C, we have a little bit different situation. Next slide, please. Where we have a large number of people infected prior to 1989 when the virus was first discovered. Prior to that time, blood banks were not screening the blood. Healthcare was not as diligent in universal precautions, and injection drug use was particularly common. All of those contributing to high incidence rates. Once infected, 70% of people remain infected for life, and they have progressed through time, progressively becoming ill with their hepatitis C. And if we don't do anything, the curve on your left is the natural history, if you will, of this cohort effect. Progressively larger number of people becoming ill and dying of their hepatitis C. So this birth cohort, people born between 1945 and 1965, represents the majority of infected people. They have about a six-fold higher risk of hepatitis C, and they represent the majority of people at risk of death, with the average age of 59 years. Now, as already mentioned, hepatitis C deaths have progressively increased. In 2012, we reported that in 2007, the number of people dying of hepatitis C exceeded the number dying of HIV. And just a few weeks ago, we reported that progressive increase in deaths has now resulted in more people dying of hepatitis C than all the other 60 notifiable infectious diseases reported to CDC every year. So that's more than HIV, TB, hepatitis B, and other conditions combined. Really a remarkable, troubling, disturbing statistic. Next slide. Now, there are things we can do about that. That doesn't have to be the status quo. That curve doesn't have to happen just because we modeled it. We can actually continue to strive to make testing and access to care the routine and the rule rather than the exception, as it is today. We've recommended that all persons in this birth cohort be tested, along with our other pre-existing risk-based criteria. We know, as was mentioned by Dr. DeSalvo, that about 90% of people who complete treatment will be cured, and that will lead to great reductions in their risk of HCV-related morbidity. And we have the prospect of saving over 320,000 deaths if we can be fully successful in our testing program and linking them to life-saving care and treatment. HIV and HCV is a particular problem. Based on the best data that's in the literature, about 23% of people with HIV are co-infected with hepatitis C. It varies by their mode of transmission of HIV, with the highest prevalence being among injection drug users, even though about 8% of men who have sex with men also have this co-infection. This is a particular problem for people with HCV, HIV, and HCV together, because HIV accelerates the progression of HCV-related liver disease. Next slide. Sorry, the risk population with the highest prevalence of HCV are persons who inject drugs, and we've known that, of course, for quite some time. Hepatitis C is more readily transmissible than HIV, in part because of a higher viral load. Those are the transmission risks listed there. They have very high incidence rates right after the initiation of injection drug use behavior. Something to be kept in mind in our prevention strategies. But in looking at the literature, just looking at ways to improve access to drug treatment and safe injection equipment can have dramatic impact on incidence rates. Now, we have been reporting outbreaks of hepatitis C in small communities for quite some time, linking that to prescription opioid abuse, and finding that these individuals were as equally likely to be male and female, mostly white, and tended to be less than 30. Next slide, please. We have found in 2014 the states colored in red are states that have reported an incidence increase since 2010. So as you can see there, this is truly a national problem, even though, as you see there on your right, that it's particularly concentrated in certain areas, such as the Appalachian region, upper Midwest, New England, and some of the other Atlantic states. Next slide, please. And I've just sort of given you, this is sort of the standard profile for people at risk for hepatitis C. Next slide. We're worried that this is having secondary transmission risk implications. This is very troubling data, in my view, from Kentucky, showing an increase in the number of pregnant women being reported with hepatitis C. Now, some of that is in part because of their change in their reporting law, but it does make sense that you have these young women becoming infected with hepatitis C who then become pregnant. So that has implications for their infant, where you have about a 4 to as high as 15% risk of transmission. So I think one of our public health challenges going forward, what are the right testing recommendations for pregnant women? What's the right management recommendations for pregnant women and their exposed infants? Next slide, please. One of the reasons we're here today is because of the concerns about Scott County, that we have observed what can happen when HIV is introduced into a social network that for many years has been the network where HCV has been transmitted. So we've had a large number of hepatitis C cases in Scott County, and then the addition of HIV there. So as we look to prevent HCV, it's obviously an excellent opportunity to prevent the introduction of HIV. We have one Scott County for HIV. Unfortunately, I believe we have hundreds of Scott counties for HCV, and some of those are also having an increase in hepatitis B. Next slide, please. Now, what can happen is that we can put together comprehensive programs, because it's better to do things comprehensively than individually. Hit the enter button again, George. This just shows you, if you just scale up needle and syringe programs alone, in a Scott County-like scenario, you get a decrease in prevalence as shown there. If you add on opioid substitution therapy, you have an additional benefit, but then if you get add on testing and linkage to care, you really get the biggest bang for your buck, where if you go in, do a rapid testing and treatment program based on this model, rapid decline in prevalence, rapid decline in the force of infection, add that together with your safe injection and drug treatment, that's how you protect communities going forward and reduce their risk in the future. So in summary, we have many successes that we can be justifiably proud of in viral hepatitis prevention, but we know we have a ways to go. Incidence is increasing for both B in some states and nationally for C. We have a large prevalent population that's increasingly becoming ill, particularly for hepatitis C in the era of curative treatments. We can do a much better job of stopping this incidence, getting those people already infected linked to the care and treatment that can truly be life-saving for them, and that will benefit public health and also benefit them individually. Thank you again for your work, and it's a really privilege to be here.